This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only. And because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome back, everyone, to another episode of the Not Your Doc podcast. I'm your host, Vanessa, and because I am expecting a baby any day, I am not with Dr. Tadros and Seth in the Midwest Hearts and Minds studios, but I wanted to pop in and say hey and introduce a two-part discussion they hosted recently with Dr. Tadros' friend and general surgeon, Dr. Michael Smith. This week's topic is gallbladder disease. In the U.S., approximately 6 million men and 14 million women have gallstones between the ages of 20 and 74, and about 120,000 require surgery for treatment each year. Interestingly, gallbladder attacks are a frequent occurrence in pregnant women, and treatment, including surgery, is often needed in all trimesters. I actually have several friends that have experienced this personally, so I'm especially interested to hear Dr. Smith talk more about this common medical condition. And now I'll kick it off to Mr. Not Your Doc himself, Dr. Charles Tadros. Take it away, Dr. Tadros.
Today we are having one of my colleagues, my friends, somebody I referred to, somebody I listened to a lot, Michael Smith. Dr. Michael Smith is a recently retired general surgeon here, but I've known Michael for 30 years. About 30 years, 28 years. Michael actually started private practice way back in Iowa, way back in 1991. He just recently retired in December of 2021. Michael has a resume as long as two of my arms. Michael was involved over the many years, everything from helping get the American Cancer Society accreditation for one of the hospitals, which is a 5-year process, I understand. He sat on critical care committees. He sat on infection control committees, surgical executive committees, ICU committees, cancer committees, credentialing committees. He was OR director for operations room director. He sat on pharmacy and therapeutics committees. He sat on what we call medical records in the old days, but called health information management. Michael started in Illinois. Medical school here at SLU at St. Louis University, and did his first year, his internship year in Detroit, and then finished the rest of his residency up in Loyola, up in Illinois, and then eventually Chicago. Yeah, and then thank you. And then he practiced in Iowa before he came to St. Louis, and he's been here for many years. So welcome, Michael. I could be more specific, but I think this gives us a feel that you know a lot, and you've seen a lot, and you've done a lot. He's done research. He's published. So welcome, Michael. Nice to see you.
Thank you very much, Chuck. It's nice to be with you.
Out of the hundreds of things I could talk with Michael about today, I wanted to talk about the basic stuff that general surgeons see whenever my patients end up in the emergency room and end up needing a surgeon. And Michael is the one I choose, or he's on call, or he's covering the emergency room, and he covers multiple emergency rooms sometimes whenever he's on call. Back in the just a few years ago, this basic stuff that I end up with my patients that end up in the emergency room were three big things that he would fall in his purview. There were hernias. There were oftentimes what we call strangulated. They were not getting blood supply, and we'll talk about these. We'll talk about specifics. Appendices. We hear about everything from kids to adults, and then gallbladders. And so the gallbladders is a popular problem in the United States, and it happens in young women probably more than men. It happens during pregnancy and peripartum period. So we'll talk about those things. Those are three big things. General surgeons cover a lot more, but I'm going to ask Michael. Michael, tell me why you end up in general surgery and how you end up in St. Louis, and can you give me just kind of a little background?
Well, I think going back way till young age, my grandparents had farms, so we worked on the farms. We had animals we had to take care of and all that kind of stuff, and just working with your hands. My grandfather on my father's side was a blacksmith for the railroad as well, so he had us out
What
doing
kind of smith?
Blacksmith.
Oh, blacksmith
He
for the
was
railroad.
he would rebuild the engines
Yeah.
and weld and cut and
Yeah.
cutting torches and all that kind of stuff. So he had us out doing that and driving. I remember driving a garden tractor when I was about 7 years old. So it just
No
went
license
from there.
needed.
No, well, we can get into some of that, but we used to be able to take the car by about 11 or so and go to town. So
Well, it's no people on wide open spaces. Yeah, they're driving trucks and stuff on their farms and stuff, or whenever they're preteens. Yeah.
So really, it was just something where we used our hands and got out there, and you really had a feel for everything, both mentally and physically.
Yep.
And I guess that was what was one of my major things in terms of going into surgery.
Yeah. It was very mechanical, manual, very visual, very visual, spatial, where you have to picture
Right.
things you can't see. You kind of can understand from X-rays and CAT scans.
Right.
Yeah.
Well, historically, from a general surgical standpoint,
Yep.
in the 50s
Yep.
and 60s, people were trained from general surgeons that they'd actually do fractured hips,
Yep.
bone settings, all kinds of different things, vascular surgery,
Right.
Even do lung surgery and stuff like that.
Yes.
So that was where there was a great appeal because there was such a wide expanse
Right.
of different types of surgery that you could do.
Back then, we didn't have as many colleges with fellowships for all the subspecialties of surgery.
Well,
back then,
we were trained and had, because there were not so many fellows, we were able to be, where by third or fourth year residency, we were actually doing the surgeries
Right.
under tutelage. And by our senior year, we were actually taking people through there to show not only that we had competency to do it,
Right.
but to train other people in addition to having the attending staff there.
so 4 years of undergrad. Typically, some people go differently, but 4 years of undergrad. Oftentimes, in the old days, it was some sort of science based, and you did chemistry.
I was a chemistry and biology double major,
major.
and studied embryology as well. with
Yeah.
that, so.
And then 4 years of med school, typally,
Yes.
allopathic medicine and also osteopathic medicine. And then you did a residency, which is 5 years, but you did
Well,
extra.
general surgery was a
Back
5-year program,
Right.
and where I originally started in Detroit, the person that I was most interested in, because Dr. Peterson was my mentor at St. Louis U, an advisor, and I was very interested in vascular surgery. In fact, I wrote a paper while I was a senior student with him, and it was published in one of the premier journals.
And
The very
Dr.
first.
Peterson was a vascular surgeon.
Gary Peterson. He was the head of vascular
Right,
surgery at St.
right.
Louis U.
Yep.
So I was interested in that, and where I went to at Sinai Hospital in Detroit, they had a gentleman there who was a cardiovascular surgeon, but his big thing was aortas, and he was actually involved in developing the intra-aortic balloon pump and was trying to get something set up where he could have a totally implantable intra-aortic balloon pump.
Right.
And during my first year, he made some, I guess, political issues that he wound up leaving my second year. And so since that kind of all that research stuff fell by the wayside, through talking with different people here in St. Louis and other places, I was able to get a research fellowship for a year in Chicago at Loyola at the Heinz VA. And so I spent a year doing research there, and then I had ongoing processes with bench research as well as clinical research from then on, and that's where I got a lot of my resume.
And your research was in endocrinological surgery, right? So this
Parathyroid, thyroid.
Yep. So I'm for our listeners. So we talk about. I'll come back, and Michael explains this better than I can. But intra-aortic balloon pumps are special for heart failure patients, and this is kind of a very special kind of implantable, temporary implantable procedure. But it's a surgical procedure back then, and now it's much run by.
Most of them are percutaneous now.
That's
they
right.
do them.
They do them through a small hole, a needle in a hole, and running something through your groin up in an artery. But that's back then. But eventually, what you eventually did your research on was the parathyroid and thyroid, which is in the front of your neck, underneath your skin, and underneath your muscle. There's a thyroid gland that looks kind of like a bow tie, and behind that are about 4 pea-sized dots that are stuck to the back of the gland, sometimes 5. It's called a parathyroid, and then the adrenal glands, which sit on top of the kidneys.
Correct.
Those are the big ones that you would be able to approach.
Most of the work that we did with the two people that I worked with, Dr. Dr. Richard Prince and Dr. Edward Poloyan were thyroid, parathyroid people.
Yes.
And Dr. Poloyan was head of research for the entire VA network throughout
Yes.
the country.
Yes, yes.
And so it was one of those opportunities for getting to work with him and getting to be able to be funded to do research was a very important thing.
Yeah.
So that's how I got into that. And then we did rotate because Chicago is a large area with multiple medical schools. We were able to go to different other institutions, Northwestern, University of Chicago, things like that, and do rotations with other people that were there.
Yeah.
And they expected us to go to the professional meetings, so we go to Chicago Surgical and meet people from all over the city.
Right.
And when we had papers to present, they'd have us present them to them. So they were, I guess they queued us up to know what we really needed to answer questions about.
So surgery residencies are kind of an old-fashioned way, and to this day, it's kind of a see one, do one, teach one type of technique. So it's a journeymanship. It's whatever we call an internship or first year, and then residency. But it's a tradition of senior people who have experience, and you come in from book knowledge and a little bit of experience as a medical student, but you come in as a resident, and every year they give you more and more responsibility. You still have to do kind of you still have to book knowledge that you have to keep up because you have to pass boards. But you see, you watch techniques, and and the more techniques you watch, the more they let you do, and then you kind of climb. And as long as you're good and you learn, you get to climb, and you have to rack up a certain amount of procedures for to be qualified.
The issue, I would say, is probably just the opposite of what it is now.
Yeah.
It used to be the more procedures you did, the better you function, the better breadth of practice that you had.
Right.
And now with so many fellowships, that people get very little of that training.
Right.
And so that's one of the things that is really, I would say, is probably as much as a benefit, as much as a complicating issue, because people don't have that breadth of practice. And now we have to have 3 practitioners doing specialized areas where I could do colorectal, I could do endocrine surgery, I could do breast cancer surgery, I could do hepatobiliary, vascular, all those types of things. So you had, where you had 3 of us that were trained like that, you'd have most of the surgical department for even a larger hospital.
So so you were trained, and you can go out any small or big community, especially small communities where they didn't have access to all the subspecialists within surgery, and you could cover a broad range of the body in terms of all the surgery, trauma, lungs, and
that's why
chest.
you see right now where you're hearing about critical access hospitals,
I've not
smaller
heard about
hospitals.
them.
There are hospitals that are, let's say, we drive down towards even Farmington, which is a larger community. But like Jefferson Regional, which is now basically a critical access, where they don't have people that are trained with that breadth of practice. So it kind of limits that. And in fact, I mean, one of the big things now is actually being where you work as a locum tenens to go to those types of hospitals to provide care.
And they're part of a bigger system that is a level 1 trauma center, so they can transport people. They can transport people, but sometimes coming from the southern area of south of St. Louis, first place you would hit would be at Jefferson, where they can stabilize you, so you can be airlifted to big.
And there's
big
a large number of all the way down Potosi and all the way down to the Boot Heel. Number of hospitals that are smaller, but they don't have the volume where they can have
support
a vascular surgeon, a general surgeon, somebody who does robotics and stuff like that, which is now the big thing, is doing laparoscopic and robotic. And that was the other thing about my particular era of training. When we started, there was no laparoscopic.
So laparoscopic is small slits, multiple small slits, instead of being the old-fashioned big scars down the middle of the belly or across the liver, the right upper belly, these big 6 and 8 and 10-inch scars. Now you can have a couple of small holes. You can insert firm rods, and you can manipulate stuff through optical scopes.
You have an optical scope that's hooked up to a television monitor camera, so you have a huge picture of how bigger. you want to do it in high definition.
The whole idea behind laparoscopy, and this is, by the way, people hear about it because of knee scopes and other things, but laparoscopy is that it was healing time, because you didn't have to heal a big 6 and 8 and 10 inch incision through muscle, and then also infection,
Correct.
and just plain old ability to get up and cough and move was a big deal compared to the old.
And I think going on initially there was a big hesitancy towards people having laparoscopic surgery because of the way it was done. A lot of the younger people did it that the older people did not want to.
Right.
They had injuries as a result of technique.
Yes.
And these injuries, especially with placement of trocars and penetrating other organs, or doing a gallbladder and winding up getting into the major liver anatomy that you don't need to be into, and those types of things. But
it's a learning curve, which is painful and slow, and but it was necessary. Yeah,
that was one of the other benefits at Loyola, because we had 3 private hospitals that we rotated to, the VA and then the university hospital. And so a couple of the private hospitals, actually through people who are residency mates 2 or 3 years ahead of me, started doing laparoscopic surgery in Chicago, among the first to do it there. And so we got exposed to that very early on.
Yes.
And my last year, the last thing that we did before we transitioned out of residency into private practice was the attending staff at the university. We took them through their first dog labs. We took them through their training to do and be able to do laparoscopic surgery on humans.
Right. Yeah, I don't think people understand, whenever they see a confident surgeon, a competent surgeon, how much hands-on, how much experience that they've had over many years, on nights and weekends, holidays, whenever the surgery is needed, because it's not always planned. How much experience people have to have in order to feel comfortable and confident, because not everybody's laid out the same inside. We're not the same on the outside, especially on the inside, as we have big variations. And when they teach us stuff in anatomy in medical school, they sometimes will tell us about variants, but it's only whenever you become a surgical resident and a surgeon that you start realizing how many variants there are in your common bile duct and hepatic ducts and all these other things, and how the vessels lay out. They'll teach you basics in anatomy in med school, first and second year, but it's only in real life that you realize it's not always the same. Sometimes a lot of it, there's a ton of variation in a lot of people, and so Well,
I think another thing that was kind of interesting, St. Louis Hugh and the Department of Anatomy, as they taught us anatomy.
Yes.
They actually had Dr. Paul Young Sr. was the head of the anatomy department, and I think it was in the late 70s or so. He actually took cadavers and had them slice them. They gave us sections that you could look and say, well, this is that, so you can picture it in a 3D manner. And the biggest thing about that was, about 3 years later, they had CT scan come along.
Yes.
So
you could correlate
that cross-sectional anatomy and comparing that with CTs was something that a lot of places didn't have that type of thing. So
we were ahead of the game.
Having our first class in medical school being anatomy, that was one of the things that really helped out a tremendous amount. So
people forget that within our lifetime, CAT scans came to life.
There were no CAT scans when we were in medical school.
Yeah, so it was just within our. I remember when the first CAT scan came to Cardinal Glennon, the pediatric hospital, whenever I was in medical school. So people forget this stuff, and we breathe. Everybody that hits the emergency room with practically anything will get a CAT scan nowadays. Back then,
they take 2 hours to do.
Yeah.
And it'd be very fuzzy things that were hard to read.
That's right.
Now you can get a CAT scan in 15 minutes with ultimate high density.
High definition.
High definition.
Yeah, 1 to 2 we can pick up 1 and 2 millimeter lesions in lungs and in gallbladders and all sorts of stuff. It's pretty.
And they can recollimate these things, so you have frontal or sagittal or.
Yeah, we can reorient. Once it's digitized, you can just reorient it, just like playing a player game. You can go around an object and you see it from multiple angles, and so now we can do that with CAT scans with the data and how much we can crunch data. So coming down to kind of what pulls you to the emergency rooms, a lot of these things are not planned. Some appendicitis is usually not planned. Gallbladders can be planned. Hernias can be planned, and oftentimes they're not. By the time they see me, So let's start talking about. Yeah, go ahead.
Specifically with the emergency room.
Yeah.
As far as gallbladders go, those are the people that will present to the emergency room because they're having acute symptoms that
Right.
are not resolving.
Right.
They may be jaundiced, they may have fever,
Yep.
a very tender abdomen.
Well, let's start with anatomy. Let's start with gallbladders. That's a good one because I get fooled by gallbladders all the time. So let's start with just basic anatomy. If you're standing up and with your right hand, if you draw your right hand up your thigh up to your side,
To
your ribs, right below your ribs sits your liver, and underneath your liver sits your gallbladder. So
Correct.
Please take it away.
Well, they call it the bile ducts. It looks like a tree. There's basically the one duct that comes down eventually from the liver that goes into the small intestine.
Right.
The duodenum just beyond the stomach. A pancreas duct attaches to it at the same location, so the pancreatic juices and the bile duct get together and they start the process of digestion and stuff like that.
Yeah. So this is people don't realize this is that I call it the gallbladder is kind of like a soap dispenser, and the soap is made in the liver. The bile is made in the liver and is stored in the gallbladder. And whenever it's like a soap dispenser, whenever you chew the food, it sits in your stomach for a while, and then it comes out of your stomach into your first part of your small intestines. That's when the duodenum, and the second part of the duodenum, which is only a foot long, it's 8 or 12 inches long.
The most important part is probably in the first 3 inches. That's where the pylorus is. That it goes from the transition of the stomach to the small
it's
intestine.
a valve.
The bile ducts are coming in there within a half inch or so beyond that.
Yeah,
They
it's very
actually cross
tight.
underneath there into the pancreas and join
Yep.
more immediately. There's a lot of blood vessels there that go to the
That's right.
stomach, to the duodenum, to the kidneys, the adrenal glands, multiple vessels to the liver.
Yep.
Plus you have the veins coming back from the intestine called
right.
the portal veins.
Portal veins, that's right.
That bring the nutrients that have been absorbed back into the liver to be processed into
Right.
energy or fat or muscle tissue and all that kind of stuff.
So the gallbladder sits there, and unlike what you may see whenever you're watching, TV shows, things are very compact, very squeezed in. The body stuffs it in like I stuff clothes into my suitcase. Every nook and cranny there's something. There's no open spaces, so everything is packed into each other, and you have to pull apart. You have to see and pull apart sometimes mechanically so that you can get to the area of interest. And you have to be very careful because stuff tears, stuff perforates, stuff bleeds. So you have to be very careful. You're doing this nowadays most of the time with laparoscope, right?
Mostly with laparoscope. There's a large contingent of people who want to do it with the robot. While the robot's very
Robot
intricate.
attached to the laparoscope on the outside.
Well, it's basically it's where there's a
Right.
machine and you
Right.
set at a console,
Right.
and you control the arms of the robot with the console.
That's right. So
it's-
you're sitting near the patient with the console with your gloves off.
In the same room,
Right, the same room,
You
right.
don't have the gloves on. You
Right.
don't have you have to wear your mask. You have to wear
right.
obviously your scrubs.
And how many
stuff.
things are poking into the patient's belly, which is a few feet away from you?
Well, it depends upon the technique that you want to use
Oh, okay.
because even with laparoscopic, before robot came along, they
Right.
developed what's called single incision laparoscopic
Oh, yes.
surgery.
Wow,
Where
yes.
we made an incision about 3/4 of an inch long, and there was a rubber thing that had multiple holes in it.
Yeah.
And it looked almost like a bobbin that you'd buy thread at the
Yep,
sewing
sure,
store.
sure.
And you could collapse it down and put it in there, and it had one hole for the camera, and it had 3 other holes
For the instruments?
for the instruments,
Yeah.
and then you could add in the typical laparoscopic if you needed more retraction or something like that. For elective gallbladders where there's not a lot of inflammation, a lot of scar
Right,
tissue,
right.
you could do that, and it would work out very well, and the patient would wind up with, most of the time, 1.5 inch incision
Yeah.
around the umbilicus,
Right.
and do that. But it was one of those things that even as somebody who has a lot of technical expertise with the standard laparoscopy with the 3 incisions below the right ribs and then 1 at the belly button,
Right, for
having
total
so many
incisions.
instruments in such a close proximity, you had to have instruments at different lengths
That's
so
right.
that your handles weren't bumping into each other, and you had to have an assistant that could hold the camera and run the camera for you and see what you were doing. And so while I enjoyed doing the elective ones like that, it was one of those things that this little bobbin-looking thing was a $300 piece of equipment that got thrown in the garbage can
Every time.
So it was one of those things because of the transition from reusable, sterilizable materials to single-use, pre-sterilized, get rid of it and move, came down to where it was an
Cost.
issue of cost.
Right.
And technically, with as much as it got thrown away with the standard, it probably still was less than what it is now. With the robot, because there's more staff that have to be involved with that. The instruments, where with the laparoscopic instruments, I could use those instruments 300, 400 times as a single instrument. So the cost of it was really pennies per case.
Practically nothing.
Whereas with the robot, those instruments are so high tech that the company itself has, with all the computerized stuff, there's chips in there that each time it's attached to the machine, it clicks one off, and you can only use those instruments for 20 cases unless it malfunctions before that. Now, where the standard laparoscopic instrument may be $300, these ones that were 20 use and throw away with all the electronics in it and everything were on the order of about $3,000 a piece.
Yeah.
So
dramatic difference in cost. Right.
Yeah, and so even if you didn't use it, the fact that it got re-sterilized, I mean, it was closer to its demise than with the other instruments. So.
Right. So coming back, so with whether you do it with laparoscopes and manually, or laparoscopes are attached to the robot, what's the robot's name? Is it Da Vinci or something?
Da Vinci is the main one. That's the one that's been around for now over 15 years.
Yeah, it's been
and they're practically, even a lot of the critical access hospitals are advertising that if they don't have it and you want to do it, that they can
bring it
funding
in
to get those things to leave it there.
Yeah.
Cost-wise, I'm not sure in a smaller institution that's
viable.
Like a $3 million piece of equipment that.
Right. Part of it is to show that they're advanced and that they care about the patient in terms of the patient experience. But you're right. In your hands, laparoscope is cheaper and just as fast, if not faster.
Well, the instrumentation you can have,
and you could
90% of it be reusable stuff, so there's very little
waste.
Dispense. With it, the instruments can be used 100 times or 200 times or 300 times without damaging, depending upon who's using them or not. I mean, that's where a lot of times with the stock instruments that they had in different cases, I had my own sets of instruments that I part paid for them myself so that nobody used them. And the people who were rough on the instruments
didn't get to touch them.
Exactly.
It's kind of like my tools in my garage. Yeah, certain things you don't want to loan out because it won't come back in the same condition. So these patients with gallbladders, I'll get back to the clinical stuff.
With the elective patients if they have a cheeseburger and fries, they may wind up having some pain between their shoulders, some heartburn, indigestion, a lot of belching.
Right.
They may eat and an hour later find that they need to be headed to the bathroom or they're going to have a problem.
Bathroom for diarrhea or bathroom to throw up?
Either or both.
Either both, yeah. Is it about an hour after you eat? Because the timing is important.
2 hours. I mean, once the food starts getting digested with the initial process in the stomach, the gallbladder within about a half hour starts to contract and excrete gall, and that's what starts the whole digestive process.
And normally that works well, but why is it a gallbladder attack or colicky pain? And what does that mean?
The biggest thing is most people who have biliary colic or gallbladder problems have gallstones, and what happens is that the bile is stored in the gallbladder. The gallbladder wall will absorb water and concentrate that. So just like making rock candy, you get little tiny stones. Some people have very small stones. Some people have actually a cast of the gallbladder where it's not functioning at all. And those people who have that oftentimes don't have as serious as symptoms because the gallbladder is not functioning.
Yeah, it's interesting.
That you'll see that, but eventually, because it's a static organ now, bacteria get in it and it gets infected, and then that's where you have a problem. And some of them hang like a cherry on a stem below the gallbladder or below the surface of the liver, so they're easy to identify anatomy. Some of them are partially, and I've actually had a couple of patients where they were actually within the liver substance that you had to be where you take that apart, and that's where you start getting into issues of bleeding and really having to know your liver anatomy. In addition to the standard anatomy where the gallbladder is located. There's a lot of variation in those things, so you need to be very well versed in different types of things because you may take out the blood vessel to the right side of the liver, and while the portal circulation's there, the oxygen and the other stuff is not so much there, and you can have segments of the liver die from things like that.
Yeah.
So it's really one of those things that's very important to know where you are, what it looks like when you first go in. Is it shrouded in the liver? Is it hanging from a mesentery that is a 15-minute operation that can be done because you can see the anatomy quite clearly. Once it becomes infected, it will more or less like causing a boil on your skin.
Right.
If it gets a lot of pus in there, it becomes terribly inflamed. And while in the native state, it's a very strong organ. Once that becomes infected and swells, it cuts off the blood supply, and now you get what's called gangrene of the gallbladder.
Necrotic
and
or dead gallbladder.
It's like trying to dip the noodles out of chicken noodle soup, as opposed
it
to
falls
trying
apart.
to get the gallbladder out in a condition that we frequently see.
Yeah.
If they're big stones, it's not a terribly big deal. If
You have to take out the whole gallbladder. You just can't take out stones. You can't suck out
if-
stuff like that. Right.
Going back to the 40s and before,
Yes.
they would actually take stones out.
Yeah, that's right.
And
They did used to have ostomy. Yeah, they used to have an
they
ostomy.
would take this. Actually, they'd sew it up and put a drain in there, and then once it had healed, they take the drain out and are there. But the reason they had the stones is because of the function of the gallbladder,
Right.
and so you tend to have more.
Right.
And that's why it's really important to know your anatomy well enough that you've got the entire gallbladder out,
Right.
and you leave a little stump of that duct from the gallbladder to the main bile duct less than a centimeter, about 3/4 to 3/8 of an inch or less, so that they won't form stones in there. And I guess if you're around long enough, you see a lot of different things.
That's right. You will.
In the old days, where they may have had something that was quite small duct-wise, they took it at the edge of the gallbladder, but this duct was 1.5 inches long.
Right.
Now it'll start to dilate up above where you put your clips, your ties, and it'll have repeat function, but it's more prone to forming stones.
Stones, yeah.
And then you say, well, it's not the gallbladder because it's been taken out.
Right.
And then you have higher propensity of common bile duct stones,
Right.
jaundice, that type of thing.
Right.
And most of those patients you tend to see them in are septuagenarians, octogenarians,
Yeah, 70,
and
80-year-olds,
they're not
yeah.
the best candidates to take back to the operating room to
Right.
do a redo surgery, which was
Right.
done open in the beginning.
Right.
So it's one of those things where, and
So-
they can be done. I mean,
Well, yeah. So these patients at risk. I'll jump back. These patients at risk are 40s and sometimes we'll see them in their 20s or whenever they're pregnant and 30s. And
we
so
see
can
during
you tell me
pregnancy-
kind of the typical patient and what the range is and why they get them at age 50 or 40?
well, I think it's one of those things. It's a common thing of diet, and it's they tend to be familial, but
Right.
families tend to eat the same types of foods.
That's a good point.
And so if the genetics of their biliary system are going to be pretty similar, that's where you'll see those. Now,
Gotcha.
we a lot of people didn't believe in what they call acalculous cholecystitis or
Yeah.
biliary dyskinesia,
Right.
meaning an abnormal function of the gallbladder
So
where you don't have stones.
No stones or sludge or sand or grit in there, but it just doesn't squeeze right. Yeah.
And then if the duct going from the gallbladder to the main bile duct is very narrow, and it gets thick like toothpaste, think of it like frozen toothpaste. It
Yeah.
just blocks the duct up, and they can't excrete it quite as easily
Right.
and get the same symptoms. A lot of people call it acalculous cholecystitis.
Yeah.
Or biliary dyskinesia.
Right.
If they're not having.
And it feels the same way. It feels colicky, cramp in your right upper belly, between your shoulder blades. And you feel nauseated, et cetera. And so you still have to take out the gallbladder for those types of acalculous.
Right, if they have persisting symptoms and it's felt that it's something that's
How do you diagnose that if they don't have stones? Whenever you ultrasound them, what tests do you do?
You can do, in the old days before nuclear medicine came along, we'd give them what's called an oral cholecystogram, where they take pills that would be absorbed into the biliary system, and it would concentrate in the gallbladder, and you could see
The contrast.
The contrast would actually shadow the stones, and so you could see these on taking an X-ray of the upper abdomen, and that was a frequent test. A lot of times, I guess in the 70s, 80s, 90s, people used to get executive physicals.
Oh,
So
yes,
they get
that's
their
right.
barium minima,
Yeah.
their upper GI,
Right. Yes.
their
We're going-
OCG, and
Right. Or
blood
glucose
tests. And
counts,
see,
yeah.
Exactly, the
Yes.
whole panel of the urinalysis and all that.
That should be. We should talk. That's a separate discussion because the people are trying to go back to that type of executive physical, but we'll come back to that another day. Yes. So so that's how they would pick it up.
They'd find it because either the gallbladder wouldn't show up on the initial dose, so
Right.
they would come back. If it didn't show up, they'd have you take another round of pills so that you got a double dose of the first dose. If they didn't show up on both of those, that was the indication before ultrasound became highly available
Right.
to see. And if the ultrasound didn't show it, that was the go-to test until the
right.
early 2000s or so, mid-2000s, I guess.
Yeah, ultrasound is like sonar, like what you see submarines. They use sound wave. They use a probe that they run over your top of your some a manual, just a handheld probe that they will run on like a greasy stick that run over your belly, and bounces sound waves off your liver and gallbladder and pancreas, and they get shadows back, and the computer puts it in kind of a format that you can see it in. And you can see ducts, and you can see stones, you can see gallbladders, you can see the meat of the liver, the thickness, the parenchyma of the liver, and stuff like that.
Blood vessels,
blood vessels, and
whole
stuff
thing.
like that. You can see flow of blood vessels. Yeah.
So, it's gotten to the point now, ultrasound is a go-to test.
That's right,
And
yeah.
even now with trauma and things like that,
Yeah.
the fast exams that you do to see is there free blood in the abdomen or belly
Right,
trauma
yes,
or
yeah, right.
something like that are things that the emergency room physicians are now being trained to do.
Right, yeah.
Well, a lot of them will do
Yes.
the ultrasound. They got gallstones. You don't need to get an ultrasound. No, because what they do is a fast exam.
Yeah.
And what we do now, where we look at where's the blood vessels,
Right.
where's the bile duct, is it dilated, how thick is the wall,
Right, yeah.
is there fluid around it? There's
Yes.
so many things that we look at with ultrasound now
Right.
that we didn't look at. And if it doesn't fall into the American College of Radiology
Right.
standards,
Criteria.
it's not a complete ultrasound. So, I mean, just to keep yourself from getting yourself up the
Right.
Peak Creek without a paddle,
Right.
you need those standardized
So
testing.
so that's important. Yeah, the people now. It used to be that you had to wait and go to from the emergency room. You had to wait sometimes hours to go to the radiology suite, where the radiology tech, the ultrasonography tech would do this test, and then there would be read by a radiologist. Now the ER doctor, while you're still in the gurney in the emergency room, can do a quick look with these quickie ultrasound machines in the emergency room and get a flavor about select things. And one of them would be a gallbladder, but Mike is saying that you really still need to go to the ultrasound suite and still get a formal ultrasound because it helps the surgeon in terms of layout of anatomy, et cetera. Yeah.
Well, I would say since probably 2020, all the hospitals in St. Louis had ultrasound people there 24 hours a day. So because this is one of those things, who's going to do the test and who's
Right.
going to
Right.
get the fee for service, so
Yep.
to speak. So
Uh-huh.
this is one of those things where there's been a battle back and forth, just
Yes.
like everything else.
Right.
This is what the established criteria are, and if you don't do that, you can't be certified to do it. So most of the hospitals now have ultrasound techs.
Yeah.
And with the
24 hours
advent
a day.
of digital radiology, those are fed right in the computer, and
Right.
the guy's sitting at home and he can go look at his computer
Right.
that has the screens on those things are amazing.
Yeah, they're wonderful
And they're now big
screens.
screens so you can see. So they can give you an official readout
Right.
at 2:00 in the morning,
Right.
and you can call the OR and
Yep.
put them on.
Yep.
If you have time at 7:30, you can do
Right.
it first thing in the morning.
Right.
So maybe even by that afternoon, they can be out of the hospital.
Yeah.
And
Right.
in a week be driving, and in 2 weeks back to
Right.
as long as they don't have 25, 50-pound repetitive lifting throughout the day,
Right.
they can be back at work.
Yeah, which is a big deal in terms of everything from hospitalization, inpatient stays, to disability after surgery, to all that stuff is a big deal, and it's because you have ultrasound tech in house 24 hours a day for these people. Because of course, gallbladder attacks only happen typically after meals, so you're eating late at night, your big fatty meal, and 2 or 3 or 4 hours later, then you end up in the emergency room for 3 or 4 hours, and somebody offers you some food while you're waiting there, and then the surgeon
can't get it till 4 o'clock in the afternoon.
Then the surgeon wants to scream because the patient ate. But this is so all these things that patients don't see and families don't see, this stacking of risk in terms of everything from your genetics to your diet that happens over years, if not decades, to the stone and sludge buildup in the gallbladder, to your ending up in the emergency room typically at nighttime, and then it goes on from there as kind of how it comes. Now, people can die from gallbladder disease, right?
Well,
from gallbladder attacks, and we
they
won't
can-
talk about cancer, but
Right.
yeah.
But, yeah. I mean, you do find cancers on occasional
That's
thing
right.
that is a very small one.
That's right.
But if it's not up in the surface of the liver portion,
Right.
way up high, it's really you take the gallbladder out.
Yeah, you're not seeing.
And if it's a small, less than a centimeter tumor, unless you saw enlarged nodes or something like that
Right.
on the CAT scan,
Right.
you probably wouldn't even need to go back. You wouldn't need
Interesting.
any other type of treatment. It's more of an incidental finding
Mm-hmm.
if it's just an interlining type of tumor.
Right.
Well, you see a lot of those types of tumors that are benign tumors anyhow,
Yes.
probably because of a chronic inflammatory process of the
Ah.
gallstones being there.
Interesting.
And sometimes if you go down to the pathology lab and look at them, you can actually see small refractile crystals at the center of those polyps
Yeah.
that were caused by the
Cholesterol.
the
Yeah,
stones,
cholesterol. Yeah.
or bilirubinate stones in that,
Yeah,
for
right.
the most part.
Yeah.
So you see those types of things. But
But whenever they become infected and inflamed, and they perforate, they can perforate.
they can on occasion. I mean, you used to see that more 10, 15 years ago,
Yeah.
especially in older patients
Right.
that may be at a nursing home
Nursing
and
home,
can't really
yes.
talk, or
They
they've had a
can't.
stroke.
That's right.
And they just know that something's not right,
Right.
and they're having fevers and now jaundice.
Right.
And so they bring them in, and you find a big, thickened gallbladder that has now become gangrenous and perforated.
Right.
And while you can do most, at least from my perspective, you can do probably most of those still laparoscopically.
Interesting.
If you can't define the anatomy,
Right.
the only other thing you can do is use your tactile, which means
Right.
open procedures, so
Right.
you can feel
Feel.
the anatomy in addition to see it.
Yeah.
And so that's where you get into the higher risk situations
Very
where
high
people
risk.
have those problems.
Right. So the perforation is that now you have pus and bile
And stones.
and stones
All throughout the abdomen.
throughout the abdomen, especially right upper quadrant. So it inflames the liver, and the stuff drains over the intestines and stuff. So now you have stuff.
You can actually get pus up above the liver between
Right.
the diaphragm
And the
it's
liver.
those are where you need drains, and if you don't drain it, it's going to come back
Right.
or be persisting.
these subphrenic abscesses. Yeah. So this becomes a whole anatomy. This is like a first year anatomy course now, where all the pus can go. How sick these people become, super sick, and they have to have drains, multiple drains, because where the pus was. Because once you close them up, once you close the abdomen up, then stuff can fester again. So you have to have an exit. So you end up putting these tunnels with silastic catheters.
Correct.
These silicone catheters, and so these people become super sick. It's a
Well,
chemical.
particularly-
It's a chemical peritonitis and an infection and
Not as
a,
much
and a septic.
a chemical because of the reaction
right.
from the infection,
Right, yes.
not from the bile itself.
Okay, not from the bile stuff. Oh,
You
I did not know
you
that.
can get bile peritonitis if you had an acute rupture
Right.
and it spread.
Right.
But one of the things that you really have to look at, especially if they've had a perforation, a subphrenic abscess, is
Yeah.
to get your hand up there and feel
Yes.
for stones way back, because if they're laying on their back, they're going
Yes.
to be behind the liver,
Yes.
between the kidney and the
Right.
liver. So you have
Right.
to really, you have to be thinking about these things
Right.
when you have specialized cases like that. And
That's
while
right.
you can deal with them by having drains put in percutaneously,
Right.
they may spend 2 weeks more in the hospital.
Absolutely. Yeah.
And be in the ICU on a ventilator and
They
all
will
these
be.
other things. So sometimes it's better to face the music, and it really
Yep.
is. That's
Spend
an
your time.
experiential thing. Of saying, do I open now?
Yep.
Do I kick the field goal, or do I
Right.
go for the touchdown on the 1 yard line? And
Yeah. So,
So-
what Michael's is describing is stuff that we talk about, and actually whenever I take a biopsy of the liver, whenever I'm trying to tap a lung and the posterior phrenic angle, but anyway, Michael's describing. I have not. Michael's describing some interesting stuff that internal medicine physicians I don't think about. He has to think about this, but we don't think about these.
that's our
these
job. I mean,
complications. Right. Yeah.
I don't worry about diabetic treatment.
No, you do
like
not.
You don't.
No,
So
you do not.
I don't know.
But
pumps
it's refreshing to hear, all this stuff that I vaguely remember from 30 years ago is coming to stuff that you have to think about every time that you have a big complicated case. So so typically, if it's an uncomplicated gallbladder, it's actually same day surgery.
It's an outpatient surgery
so you
where
walk-
they come in the morning, and even as late as like 3 or 4 in the afternoon.
Oh, yeah.
A lot of time. I mean, with the COVID and stuff, changes. A
special.
lot of stuff changed because of volume and stuff like that. So because of staffing and
Right.
not having
Right. Big
recovery
difference.
staff till 9:30 or 10 o'clock at night.
Right.
Obviously, if I can send you home at 10:30 at night and you not have a room charge,
Right.
you're saving $1,000 or $2,000 a day
Easily.
even as an overnight stay.
Right.
So it's worth it to have a nurse or two that's there.
Right,
If
right.
you've got 4 or 5 patients that are in that kind of condition between the various people who are doing that surgery. So
afternoon, right.
That's.
But you could take it, yeah. So it's amazing to people. If it's uncomplicated, you're not in an acute attack where you've got plugged off gallbladder, you're not jaundiced, not feverish, you're not throwing up and stuff like that, that you can be electively brought in and go through this and go home the same day.
And I would tell you, too, if you have patients that don't have a lot of issues with anxiety.
Yes.
If you don't have patients who are taking pain medications for
Chronically.
their chronic knee problem
Right.
or whatever else,
Right.
You can get those patients out of the hospital. And I would tell you probably 80% between the combination of Aleve and Tylenol that they don't need much more than that. Maybe an ice bag to prevent some of the throbbing around the umbilicus.
Right.
And if they get up and stretch out and stand up straight and get a good erect posture, they can be where in 2 or 3 days they're maybe Tylenol to go to sleep at night,
Right.
And stuff like that.
So what people, because we've talked a little bit about chronic pain and what we talk about, but these patients, what you're describing, you can cut through their skin, the subcutaneous fat, their muscle, and put and so this hole that you could put your laparoscope through a couple of them, up to 4 of them if you're doing the old-fashioned way, or 1 of them if you're doing the new technique. You can go inside and manipulate the gallbladder, pull it away from the liver, clip off the gallbladder, the bile duct.
You don't want to clip the bile duct. You just
You're right.
the cystic duct and the arteries.
Cystic duct and cystic artery.
Occasionally,
Yeah.
A vein or something you
Right.
may see there as well.
So at best it would
So they're
be
controlled.
three clips. Is that right?
Yeah.
Three clips. And you can you take out the gallbladder intact in a sack through that 1.5 inch.
Usually we put a sterile bag that's on a handle that you push down, and the bag opens up.
Uh-huh.
It has a little ring to keep
Right.
it held open.
Yep.
And you just stuff it in there, and it has
Cinch it and bring
up,
it and pull it out
bring
through the
up,
hole.
And
So
with
things,
the, with the
so all the
patient
all the
asleep,
contents are intact inside the gallbladder.
and the bag
Mm-hmm.
is very. It's not like a little Ziploc. It's really very. It's almost like a parachute type fabric.
Yeah,
So
sure.
It won't
Like a
rupture or
Dacron or whatever it is.
Right.
Yeah.
So,
So
you can do that. You can actually take a large hemostat and stretch that incision while I'm not making the
Sure.
incision bigger.
Right.
With
You can
your
stretch
sleep,
it,
I
right.
can stretch it out.
it's a type of clamp that he could stretch the opening, and so you can pull out the bag with a gallbladder in. How big is a gallbladder typically? It's the size of my what?
a
is it?
normal gallbladder that doesn't have stones is probably about the size of one of the kids' party balloons you get. Those little tiny things.
Yeah.
It'd be like
So
that
a
if you
deflated
went to the
one.
dollar store and
Deflated,
got
yeah.
those little-
Dollar store party balloon that's not inflated yet. Yeah.
Right. Now, I mean, I've seen a couple of them actually is almost as big as 2 fists.
2 fists. So they're
And that's
inflamed
where-
and full of
Right,
pus
the-
and everything else.
But
yeah.
those are the ones you have to really watch out for,
Right.
the big ones, because the anatomy could be could
Very-
be a variant, or
right.
it could be it's just been not functioning for
Right.
so long that it's just dilated itself up.
Right. And so it's amazing that Tylenol and Motrin for this big of a procedure. The procedure is 45 minutes if it's uncomplicated.
Yeah, 30 minutes.
30
half hour,
minutes,
45. Yeah.
From skin to skin. Mm-hmm. So from insertion of the from cutting to get the trocars and then the scopes in to suit the last few sutures of the little incisions.
Right.
It's 45 minutes and stuff. If
Well,
it's totally uncomplicated, the patient's healthy. Blah blah blah. Yeah.
In an elective situation with a not
Yeah,
morbidly obese patient,
Right.
it takes as much time to put them to sleep and to wake them up as it does to
Yeah.
do the surgery.
Right.
Okay. And that's if the team's got everything set up.
The
and
team
it's ready
works
to
with
go
each
and
other. Right. Yeah.
You know,
And
it's
then-
like
so people
playing
need to know.
piano versus having a concert band. I mean, if everybody's
Yeah.
if everybody's on the same page,
Right.
it's
And that's
a
totally
work of
uncomplicated.
art.
Complicated one could be multiple hours.
Yeah, I mean, it's not about the time; it's about the quality of the
Right,
procedure.
of course.
So, if there's something you're not sure of, or
Right.
you're there,
Right.
if I take my time laparoscopically, or I put an extra instrument in for better exposure,
Right.
that frequently, I would say probably 9 out of 10 times would be why we do that.
Right. Yes.
And that gets us down into that 2% range of having to open because complicated anatomy,
Right.
complicated procedure,
Right.
that type of thing.
So
And
2%, you convert about 2% of laparoscopic procedures
I
as you
would-
start like that. You convert two out of every 100. You have to convert to an open procedure.
Probably about 1%.
1%.
Yeah.
So you have to convert because things are not what they seem by CAT scan or ultrasound.
Right.
Before you got
And
stuff
there
like
are
that.
cases too,
Right.
where one of the things we see a lot more now than we did before is because people have had so much different types of laparoscopic
That's right. They
surgery
have. That's right.
that you go in the simple way, and all of a sudden you're dealing with an hour's worth of adhesions or scar tissue from the other surgery.
So we should talk about that briefly.
Especially hernias. I guess that was where I was.
Good. So hernias is one of the issues. So intra-abdominal. This is not liposuction where you don't enter the what Michael's talking about is entering the coelomic cavity, which is inside the peritoneum underneath. So you go through the skin and fat and then several layers of muscle. Now you're in the area. So that's when you get adhesions is inside the muscle. So these people are having bariatric surgery, and they're having hernias.
Hernias, colon surgeries.
Colon surgeries.
They're now doing adrenal glands. I've done a couple of adrenals laparoscopically.
Anytime you enter the belly, you set up for adhesions, which is scar tissue. It's inflammation, even if there's no infection and stuff like that. Just entering the belly. In the old days, whenever we just had powder on our gloves, that would be enough to trigger an inflammatory response in adhesions and stuff like that. So the adhesions muck up the works in a bunch of different ways. Certainly, for you to be able to expose what you need to see through the scopes and stuff like that, that adds a ton of time and risk.
I think that something is very unusual cause of that. When I was in residency, we had a patient who had come from one of the Eastern Bloc countries where tuberculosis was much high.
Right.
And we get in there, and it was amazing because it was like all these little white dots all over the place. Everything stuck together.
Right.
It wasn't like liquidy.
Right.
This was like peeling the thing off of an orange.
Yeah.
And then we sent it, and they said, well, this is tuberculous peritonitis. I mean, that's the only time I ever saw that.
Yes. Yeah. We're caught off guard. I have an uncle who's in his 80s, and the TB of the bladder. You could have TB of the vertebrae of the spine, POTS disease, and so yes, it's you always have to be, even though you're a surgeon, you have to know a lot more than just the anatomy and stuff like that. You have to be an intern. You have to be an infectious disease specialist. You have to be an internist. You have to do a lot of stuff. Any good doctor would be just like you. So typically, these people will not. You'll never have another gallbladder attack again because your gallbladder's out. You typically don't make any more stones, even in your ducts. But in the old days, we used to have to tell people no more fatty foods but that's changed. Tell me about the old days versus currently about diet post-operatively.
I guess what I would say, the first thing about the diet is the first thing we say about the general population.
Yeah, well, of course.
The dietary. Following the diet is not like it used to be, where you can't have fried food, Grandpa, because your heart attack, and he didn't take fried food. You know what I'm saying? Now, the diet, you can have patients who have biliary colic from an acalculous gallbladder or dysfunctional gallbladder, and they may wind up getting spasm in their biliary tree.
Yes.
Exclusive of the gallbladder because it had been going on for years. And it may be 6 months before you see, and they say, well, every time I had that cheeseburger and French fries and a bowl of chili, it still lights me up. And it's like, well,
just give it time.
Put the fire extinguisher and give it time. And most of those tend to go away over time. So
you're describing something as smooth muscle that lines these ducts, still spasms, even though the gallbladder's gone, and everything else. Some of the stuff that's interesting.
Think of it as Charlie horse of the bile duct.
It is. It is a type of Charlie. It feels like a cramp. It does in your upper belly, in your chest. It's mistakes for a heart attack between your shoulder blades.
Sometimes in the older patients, they think they're having a heart attack because its pain is up high, just below their breastbone, and into their shoulders.
That's right.
And that's, I think you're having a heart attack. And they run to the hospital and they find out that it's their gallbladder.
Right. So nowadays, I tend to tell people you may have diarrhea for a little while because now your food, you still, now the liver is making bile all the time, it's dripping in the intestines all the time. Is that right?
Well, the bile duct will dilate to take over that storage function.
I did not know this. Yeah. I mean, I know they dilate, but I didn't realize that it was part of the storage function.
A normal common bile duct with the gallbladder intact and functioning may be anywhere from 6 millimeters to about 9 millimeters.
Okay.
And it can get up to about 13, 12, 13 or 1.3 centimeters.
Right.
is in the proximal biliary system, and probably as much as 7 or 8 millimeters down close to the stomach or the small intestine.
Right.
And so it will dilate to take over that storage function, but that part of the mucosa does not absorb water.
Right.
So you tend, I would say, you tend not to form stones.
Right.
And that's one of the things that, from a technical standpoint, you want to leave a half a centimeter or less of the cystic duct.
Or also
that will tend
to form stones
or you
within
form
that.
stones within that and can cause the same types of problems.
Yes.
And those are much more difficult to diagnose because the
Right.
OCG you can't use.
Right.
The ultrasound may not give you a good thing because the clips have been titanium.
Right.
They're starting to use some of the plasticky type things that are dissolvable clips.
Yeah.
But the problem with the dissolvable clips is if they dissolve too fast,
They release too
then you
soon.
wind up with a bile leak that may not shut down because there's no
Right. All these little
back pressure issues.
Yeah, it's interesting. Well, good. So that kind of covers kind of a good chunk of this stuff. I'm going to. Is there anything else that you think that you would tell a patient that's going to undergo surgery? I know you have your own pattern that you've done for decades. What you tell them about the pros and cons and watch out for?
I would say, everybody has a routine in terms of what they recommend. Some patients will actually come in and they'll shave their abdomen and stuff like that in men. They shouldn't do that because all the studies show the shortest time between the razor on the skin to shave until I prep the skin is the lowest incidence of infection. And that's our biggest problem with external, because any wound can become infected.
Right.
So we want to do that.
So no need to shave before this type of
Especially don't use depilatories because they can damage the skin as well.
Depilatories are like sodium hydroxide, which is in Nair, to kind of eat away at the hair, right? And so that's a problem too. Yeah.
So those are the biggest things. And after surgery, most of us now have started using a glue-like substance that will close instead of that. You don't pick it off, you let it go, and it'll peel off like the old blister skin on a blister.
Right.
And it'll stay on for about 2 weeks. Some of us had routines after the surgery that we would basically, I would do a second prep of the abdomen after I was finished. We took all the stuff off, clean that off, and then put this glue material on our wounds. It's not a Band-Aid, so it's not going to stick to your skin or to your clothing when you're moving around. And usually by the time I see them back in the office in a couple of weeks, it was ready to peel off. And half of them are like, I don't want to peel it off myself. So it's like,
that's the superficial. That's the dermis. But you suture, you staple below.
Because hernia, which I don't know if we have time to talk about those.
We'll talk about it a little bit.
If you have incisions for around the umbilicus, because that's the focal point of where the muscles react. I usually would use a non-absorbable suture at the muscle level.
Okay.
I would put in a couple of them independently, so that if one broke,
it doesn't unravel. Doesn't unravel everything.
Doesn't unravel.
Postoperative hernia.
And then you wind up with a hernia, which now is a bigger deal because it's going to be another surgery.
Right.
You're going through scar, and it's going to be harder to get it, and it's going to heal less effectively. So then we talk about mesh and all that kind of stuff if we need it.
Right.
So the biggest thing is the first 2 weeks to not push yourself to where it's causing you discomfort. And you say, it doesn't hurt, it's just uncomfortable. Well, it's because you went and carrying in a bag of groceries from the grocery store, and it's 15 or 20 pounds.
Right.
And it hurts only when you do that. You're putting stress on that wound before it's had enough time to heal, because if you get activity-induced discomfort more than after the second or third day, it's because you're putting stress on those sutures.
Right.
A lot of people are now using absorbable sutures, so if they do that, and this suture happens to be a small enough caliber, it's like going bass fishing with a 2-pound test line. If you're a fisherman, you're not going to bring it in because it breaks. And once it breaks, that opening opens up, and eventually you'll have a hernia there.
Right. So I can see from your experience, you kind of know that you want to stop secondary complications from. And whenever people, what you're talking about, whenever you talk about 15 or 20 pounds and stuff like that, is whenever anybody has to lift anything. What happens is we tighten our abdominal muscles, and it will pull. There's a lot of forces around holes. Anytime you put a hole through stuff like that, there's
the edges of that opening of the muscle will want to pull away as
from
well.
each other. Right.
And since it's not under tension already, it's going to have more tension to pull the center of it, which means it's more likely to break an absorbable suture.
Right.
So as time progressed, we used non-absorbable sutures in the umbilicus and found that it did.
And that's the whole purpose of sutures or staples and glue, is because there's a natural healing process, which is inflammation and some scar tissue and collagen and stuff that comes in. And so it takes how long before you say the skin is back up to normal tensile strength after you?
Well, if you did studies on that, you could find some differences in the tensile strength starting at about a week. Mm-hmm. On out to about 3 months. Beyond that, you're not going to get much more healing. Right. If you do a lot of the stuff that you put a lot of tension on the skin itself, you can potentially induce scar formation, so you get larger scars. Mm-hmm. Some people get it with what's called keloids, which is hyperactive healing processes, and it can be where those keloids can be very hard and firm, and every time you lean up against something, it causes tender pain. Yeah. And so it's one of those things that once you get that, it's not just through the skin, it's through that whole depth. And so even taking the keloid out that you see does not necessarily get rid of the pain.
Yeah. Because there's nerves that also become entrapped, and vessels and nerves that become entrapped.
It's like a rusty hinge. It doesn't want to move like it normally would and stretch and things like that. And that's why those nerves get encased in the scar tissue, and then when you move it, it's like
electric shock and everything else is miserable.
Burning, type of thing.
Michael, thank you. It was not a basic science. This was a high level. This is a master level course about everything from technique to anatomy. And so I really appreciate it. Thank you very much. And this is Chuck Tadros, and we'll be back soon with more Michael Smith.
Thank you, Chuck.
Hey, y'all, it's Vanessa again. If you would like to get involved with the podcast, we would love your feedback to our email address at notyourdocpod@gmail.com. As always, you can check us out on Spotify or YouTube, and our website, notyourdoc.com, is up and running with links to all episodes and Dr. Tadros' original Not Your Doc blog. We'll catch you next time.
This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.